Falls represent the most common cause of accidental injuries and fatalities among elderly individuals in the United States. Notably, cognitive impairments, CI, ranging from mild cognitive issues to dementia, significantly increase both the likelihood of falls and their consequences in this population. In fact, older adults with cognitive impairments face double the risk of falling and are 3 times more likely to suffer severe injuries such as fractures or head trauma compared to their cognitively intact peers. To combat this, fall risk management, FRM, programs, including interventions like reducing hazards at home, physical exercise, educational support, assistive devices, and multifaceted approaches, aim to lessen falls and related injuries among cognitively impaired older adults. While these initiatives have shown success with older adults without cognitive issues, the effectiveness within the cognitively impaired group remains uncertain, highlighting a research gap in tailored FRM strategies for this vulnerable demographic. A key obstacle is that the cognitive and functional decline in these individuals, such as worsening gait and balance, can disrupt their ability to stick to FRM program routines. Therefore, the involvement of care partners, family or friends, becomes crucial, assisting these older adults in following through with fall prevention efforts. Previous reviews reveal that care partners contribute by receiving targeted training, collaborating with healthcare teams, and helping the cognitively impaired access necessary services. Recent findings further underscore that their active engagement improves adherence to FRM programs by identifying risks and supporting lifestyle changes to prevent falls. The idea of care partner engagement, CPE, in dementia care, however, has been studied less rigorously. Defined broadly, CPE reflects the meaningful participation of care partners in caregiving activities and coordination with both the older adult and healthcare providers. While multiple FRM reviews acknowledge care partner involvement, they rarely explore how CPE is precisely defined or measured, hampering efforts to understand facilitators, barrows, and tactics to boost engagement. Clarifying this concept is vital for developing interventions that truly integrate care partners, enhancing outcomes for cognitively impaired elders. Building on frameworks from other health fields like pediatric mental health and chronic disease management, this study conceptualizes CPE within FRM as a dynamic process encompassing 5 core elements: enrollment, initiating participation, attendance, presence at sessions, active participation, quality involvement and behavior changes, completion, fulfilling program requirements, and maintenance, sustaining acquired practices post-program. Each aspect captures unique engagement behaviors and responsibilities of care partners. Using this framework, the study embarked on a systematic review aiming to 1. Identify how CPE is described and measured in FRM programs, 2. Uncover factors that enable or hinder each CPE component, and 3. Examine strategies implemented to enhance CPE and their impacts. The researchers followed rigorous protocols aligning with PRISMA guidelines and registered their work with Prospero. Their comprehensive search spanned numerous databases from 1985 up to 2023, later updated in 2024, focusing on peer-reviewed English-language studies involving human participants. Eligible studies included at least some references to care partner engagement in FRM interventions for cognitively impaired older adults living in the community. Screening and data extraction were independently conducted by multiple authors using systematic review tools, ensuring adherence to inclusion criteria and mitigating bias. Studies were analyzed using both qualitative and quantitative methods to classify CPE concepts, identify barrows and facilitators across care recipients, care partners, and providers, and assess the effectiveness of engagement strategies. The review synthesized findings from 32 studies, most employing quantitative methods such as randomized controlled trials, with others adopting qualitative or mixed method designs. Programs were primarily exercise-based or multifaceted, sometimes including education, technological aids, or home hazard modifications. Participants averaged around 79 years old, with care partners typically in their late 60s. Most care partners were informal caregivers like spouses or family. Quality assessments showed that although few studies directly focused on CPE, most provided valuable data on engagement components. However, qualitative data quality was variable, highlighting a need for more robust research designs in this area. The review found inconsistent terminology and measurement approaches for CPE. Terms like e-adherence were used broadly without clear definitions, potentially obscuring specific care partner roles. Quantitative measures included attendance rates, completion percentages, and duration of involvement, while qualitative assessments often relied on observation or self-report. Facilitators of CPE included motivation, interest, perceived benefit, care recipient and care partner health status, supportive program design, and accessible resources. Conversely, barriers ranged from health declines, scheduling conflicts, relationship strain, lack of dementia knowledge, to logistical issues like transportation or technology access. Notably, enrollment and maintenance of FRM practice post-program were underexplored and presented unique challenges, such as difficulty identifying eligible participants and sustaining long-term engagement. Strategies to improve CPE encompassed community outreach for recruitment, flexible scheduling, behavioral change techniques, provision of training and resources, and ongoing support. Positive impacts were reported for attendance and active participation strategies, though effects on enrollment and maintenance remain unclear due to limited evaluation. This review exposes a critical need for clearer CPE definitions, standardized measurement tools, and targeted interventions that address individual, relational, and systemic factors influencing care partner involvement in fall prevention. Motivation and multidimensional support stand out as pivotal elements, with programs encouraged to adopt person-centered and flexible designs that alleviate burdens and enhance engagement. Controversially, this raises questions. Are current FRM programs truly reaching and supporting the care partners who need it most, especially in underserved populations? And how can programs balance the complexity of cognitive impairment needs without overwhelming caregivers? These are pressing issues warranting deeper investigation and community dialogue. In summary, while care partner engagement is recognized as essential in managing fall risk for cognitively impaired older adults, research and practice have yet to fully harness its potential. Enhanced clarity, rigorous evaluation, and inclusive program design are essential next steps to empower care partners and improve outcomes in this vulnerable population.